So dear attendees, welcome at the Cochlear Science and Research Seminar on Advancing Active Transcutaneous Bone Conduction Hearing Solutions. My name is Bart Volkaerts. I'm the Vice President of Clinical Affairs and Market Access for Europe, Middle East and Africa in Cochlear. Let's remind ourselves that this webinar is a forum for education and information sharing amongst research partners. It is our mission at Cochlear to help people hear and be heard by empowering people to connect with others and live a full life, by transforming the way people understand and treat hearing loss, and by innovating and bringing to market a range of implantable hearing solutions that deliver a lifetime of hearing outcomes. Let's remind ourselves to some figures. Indeed, more than 1.5 billion people worldwide live with hearing loss. And this includes around 60 million who live with severe or higher hearing loss. From the latest report from the World Health Organization, we know that 1 in 3 people over the age of 65 are affected by hearing loss. And also less than 5% of the people who may benefit from a device have received one. And these figures are not different for candidates for bone conduction hearing solutions. And I'm therefore very happy that during this symposium, we will hear more on how bone conduction solutions can become the standard of care. Now, talking about bone conduction solutions, let's talk about devices. And here we show the 3 systems that we can offer today. We have the Baha Start, our non-surgical bone conduction solution, Osia system, and the Baha system. And those 3 systems comes together with a range of applications, true wireless devices, fitting software, and surgical tools. We will hear during the symposium also a few presentations on the MRI compatibility of the Osia system. And already in the early development phase, we carefully selected the transducer technology. We selected the unique piezoelectric power technology. And this technology is enabling the MRI at 1.5 and 3 Tesla. It brings the opportunity to deliver a discrete and easy-to-use system, and that comes all together with high-frequency power and performances. At the same time, the piezo technology is offering a reliable system, a reliable implantable system. The reliability numbers are easily hitting our targets with a 99.76% cumulative survival percentage. Now, this is a time for me to handing over to Professor Jaydeep Ray from the University of Sheffield and Dr. Faisal Zawawi from the King Abdulaziz University. Jaydeep, Faisal, the floor is yours.
Thank you very much, Bart. May I introduce my co-host first, Faisal Zawawi. Dr. Faisal Zawawi is a pediatric otolaryngologist and a fellow of the Royal College of Surgeons of Canada. Dr. Zahawi is the chairman of the Cochlear Implants and Hearing Aid Unit in King Abdulaziz University and the director of the residency training program at the Department of Otolaryngology and Head and Neck Surgery. He's published more than 70 peer-reviewed publications and many book chapters. He is on the editorial board of Otology, Neuro-Otology, Open, and a regular reviewer for many journals. His main research focus is on auditory and speech development in children with hearing impairment.
Thank you, Professor Jaydeep Ray. and I'm happy to be here with you in this wonderful forum. Professor J.D. Prey is the Professor of Otology and Neurotology at the University of Sheffield and Professor of ENT at Sheffield Hallam University and Clinical Director of ENT and Hearing Services at Sheffield Teaching Hospital. He has wide experience in training, research, and innovation. His main research interests include complex hearing loss, auditory implants, and innovative balance management. He is also the specialty lead for ENT for the National Institute of Health and Research and has also served as the training program director of ENT and a member of the Specialist Advisory Committee of Royal College of Surgeons and the Otology Council of Royal Society of Medicine. He lectures widely and has been the chief investigator of several large international multi-center research projects. Outside of medicine, he was the High Sheriff of South of Yorkshire and currently Deputy Lord Lieutenant of South of Yorkshire. Thank you, J.D. Ray, and Professor Ray, the floor is yours.
Thank you very much, and hello, everybody. Without further ado, I'll just do my introductory talk, which is essentially on healthy hearing ears and acoustic implants. The healthy hearing ears and acoustic implants go together, and I'll briefly touch on why, and that follows on from Bart's initial presentation. So, brief background, as Bart mentioned, there's a huge volume of disease which leads to a hearing loss leading to early dementia. We did a small study funded partly by NIHR, looking at the use of hearing devices. Bilateral was the commonest group. Age groups, the senior citizens were more commonly users of hearing aids, especially the bilateral ones. Awareness of any alternatives to acoustic hearing aids was very low and support was very low. Hence, there was a significant amount of social isolation in these patients with unrehabilitated hearing loss. So the challenges were that these patients were in different stalls, primary, secondary, community care, and the gap was quite obvious, and therefore there was less of a coherent strategy in their treatment, and there was a lack of proper patient pathway. So we developed the Healthy Ears project, which looked at breaking the vicious cycle of using hearing aids, ear infections, not using hearing aids, and then going back to that social isolation. And we found that the introduction of alternative hearing devices like bone conduction and acoustic devices broke that cycle quite well in the relevant patients. And the results were quite obvious. The discharge of the oral discharge of these patients decreased significantly. The patients experienced a better quality of life, and education together with that of referring audiologists helped their confidence in sending these patients to the appropriate centers. And the BAHA or the bone anchored devices present at that time were very useful in improving their hearing. That led us to grow what is now called the Healthy Hearing Ears Initiative. This is a global initiative, and participants are from Canada, Colombia, all the way across Europe, Asia, and Asia, including Dr. Zahawi on this panel and the colleagues from Australia and Hong Kong. And we've been very active in this group in looking at various aspects of ear disease. So the main the task of this group was to look at the global impact, the focus on infection and the results of ear infections on hearing, and to develop consensus documents and guidelines. The economic burden is the other aspect that is being studied now as the Healthy Hearing Ears group. And I won't go into the details of this slide, but Bart already mentioned the load of the disease in the global population. And the utilization of healthcare resources by this group is enormous. So, and that has been as a publication which can be accessed freely, and the reference is there, which I'm sure the audience participants could access later on easily. We also had publication on the consumption of healthcare services and the rehabilitation strategies of these patients, and those references are on the slide. Now, the advantage in the UK is that all acoustic devices and cochlear implants are funded bilaterally from central commissioning, and it's a state-funded service. And then we've looked at the spread of acoustic devices and other implants across the hearing spectrum, and the slide here shows that clearly. It brings me to our experience of the Osia. I have excluded all the other devices that we've used so far. The Osia, as mentioned, is the piezoelectric active implant, which is now available for use. And we have had significant experience of this, and I'll share this briefly in the next couple of slides. The initial first generation was introduced as a trial, and we were part of the first generation in 2019, 10 each for 5 centers across the world. And the results were straightforward surgery, no complications, good audiological gain, as is evident from the results. We continued our work throughout the COVID period through virtual meetings and published our findings and consensus findings across that group, and then went on to use the Osia 2 system that is now the commonest one available. The incisions are of different types, and we're not going into the details, but various incisions have been tried: horizontal, C-shaped, J-shaped, and a curvilinear one. A majority of the incisions work, and I'll let the other speakers describe them for us. So far, we've done 120 in adult population. The results are extremely satisfying. The spread of indications is shown there. Apart from 3 explants from patient-related causes, the results have been absolutely satisfactory. All the devices have been stable, and no device failures have been reported so far in the last 4 years. And the publications on transcutaneous devices are there for you to say. The 2 key take-home messages are: active transcutaneous systems outperform passive transcutaneous system, and transcutaneous bone conduction systems outperform percutaneous systems on multiple levels, not just on skin infections, skin conditions, and skin overgrowth issues, but also audiologically in some areas as well. So to conclude my talk, the surgery for the Osia itself, which is the current active transcutaneous piezoelectric device from Cochlear, the surgery is straightforward, no major complications noted, good audiological gain, high patient satisfaction, can be done both under GA and local anesthetic as a day case procedure, small number of skin-related issues in our series from patient-related conditions, no device failure. Thank you very much. So my role would be to hand over to the next speaker, which is Dr. Eva Goldberg-Bochhorn. And Dr. Goldberg-Bochhorn is a leading specialist and head of the Hearing Center in Ulm, in University Medical Center of Ulm. She's renowned for her expertise in otolaryngology and her innovative research in hearing solutions. Dr. Goldberg-Bochhorn is particularly noted for her pioneering work on active transcutaneous bone conduction hearing devices, which provide effective treatment for patients with conductive and mixed hearing loss. Her contributions have significantly advanced the field, improving hearing outcomes and quality of life for many patients. Dr. Goldberg-Bochhorn, the floor is yours.
Thank you, Professor Ray, for the kind introduction. It's a pleasure for me to present you our long-term results regarding the patients implanted with the Osia system. The Osia system was released in Europe in 2021, and it's a system that you can implant and use in patients of all ages, in which the anatomic situation is adequate and which weigh over 7 kilograms. In principle, it is recommended for patients with bone conduction thresholds up to 55 dB, and in single-sided deafness patients with thresholds of 20 dB in the better ear. And here you can see the hearing thresholds of our patients with mixed and conductive hearing loss, preoperatively and postoperatively. And as you can see, there are no changes, and the thresholds are stable after the operation. Even in those cases where we did second look surgery or revision surgery simultaneously. Patients who match the audiological criteria and suffer from conductive and mixed hearing loss may have atresia or middle ear malformation, or they had multiple tympanoplasties due to cholesteatoma or chronic middle ear diseases. And Osia will also be offered to patients with single-sided deafness if cochlear implantation is not an option or not wished by the patient. Until today, we have implanted 35 patients, 7 of them bilaterally. We implanted 11 children. The youngest child was 4 years old, and the age of the adult patients ranged between 20 and 80 years. And most of our patients have mixed or conductive hearing loss, and we have 5 cases with single-sided deafness. I will now show you our existing long-term data of 24 patients. They are all using their implant for at least 1 year, as you can see here in the table and the follow-up. And our youngest patient is about 3 years in the long-term follow-up. And I will divide all the cases in 2 groups, 20 years with conductive and mixed hearing loss, and 4 patients with single-sided deafness. Prior to the surgery, our patients tested bone conduction devices, mostly the Baha with the soft band or the sound arc. And all patients had MRI and CT scans to exclude intracranial pathologies and to facilitate preoperative planning of the positioning of the BI and the Osia implant. The aided hearing threshold significantly improved compared to the unaided situation, either with the test Baha or with the Osia system, and the results were stable in the long term. Also, the speech reception scores in quiet measured at 55, 65, and 80 dB with the Freiburger monosyllabic speech test were clearly improved with the test device and the Osia system compared to the unaided situation, and we found a markedly improvement between the test device and the Osia system. The speech reception scores in noise were also improved in almost of these cases in the short and in the long term, and we determined the signal-to-noise ratio at which the patients understood 50% of the sentences with the Oldenburger sentence test. And the graphs here show you the results in 2 different hearing situations. On the left, there's sound and noise from the front, and on the right, sound from the front and noise from the contralateral ear. And the blue box plots depict the improvement of the scores in noise. And we had an improvement in almost all patients. Some final words about the single-sided deafness cases. In the left diagram, you see in blue the hearing thresholds of the hearing impaired ear, the deaf ear, and in gray the thresholds of the contralateral ear, and the red line depicts the aided thresholds with the Osia when the contralateral ear is deafened with earwax and headphone. And the Osia system also improved speech recognition scores in noise. As you see on the right side, we had only 1 patient who had a worsening in the long term. And these are only some examples of our patients to demonstrate the aesthetical aspects. We had very good results in almost all cases, especially in the children, as you see here in case 1, 4, 5, and 41 and 33. And we had also cases who formerly had other implants, as in the middle case 2. The patient had a cochlear implant in single-sided deafness, but he did not benefit from the implant, and we decided to implant the Osia system. And in those cases, you have to pay attention to the former scars. Only in single patients, we saw an eye-catching hump behind the ear, as you see here on the right in case 36. This was due to because we couldn't do an implant bed, and the skin was very thin, but the patient was satisfied. In one case, we had temporary skin ulcer above the implant magnet because the magnet of the speech processor was too strong, and the wound healed within several days when we changed the implant magnet, and the patient didn't wear the processor for several days. One thing that I want to mention are cases with asymmetric bone conduction thresholds, like in this example. You have to consider that a bone conduction implant will stimulate the contralateral ear. And in these asymmetric cases, Osia will work like a cross hearing aid. And though you have to counsel your patients or to decide for another implant. I will now conclude. The Osia system is a good option for patients with mixed and conductive hearing loss within the proposed indication, and for patients with single-sided deafness if hearing remains stable over time. You should consider other acoustic implants, probably if bone conduction thresholds differ. And Osia is especially suitable for atresia patients, even at young age. You can combine the implantation with ear reconstruction surgery and epithesis. And I think Faisal Zawawi will talk about this in the next talk. And it is also a good option in patients with radical cavities, and the combination with revision surgery, in my opinion, is possible if indicated. And to avoid a distracting hump, an implant bed may be a beneficial option. Thank you for your attention, and if you have any questions, you can use the chat, and we will discuss it probably later on. And now I will hand over to Faisal Zawawi, who will talk about his experience with children with atresia, and I'm very curious about this topic.
All right. Thank you, Rebecca, for this wonderful talk. I think this is a nice segue to what I'm about to talk to you guys about in terms of the utility of the Osia system in children with microtia. One of my only disclosure that I'm part of the Healthy Hearing Ears Association initiative, which Professor Ray has spoken to you about it. It's really a teamwork that helps us get these children cared for in an optimum fashion. We need our nurses, our audiologists, speech therapists, our trainees to help us improve this care of these patients. So a bit of a background of the problem. Well, what do children with microtia suffer from? Well, first of all, they have a hearing issue, and the second problem is they have a cosmesis issue. But most of the families present to us due to the cosmesis issue. And the reason behind that is that the hearing issue takes a step back because usually they have a unilateral microtia, which means that the patient has good hearing and good speech. But the problem is they have issues with sound localization. They may even have issues with school performance, as you won't be able to sit everywhere in class, and they have to have specific preferential seating. And if they're not in the proper position, they might not hear the teacher well. So there have been many auditory solutions for these children. One of them is the non-surgical bone conduction devices, who Brad has spoken to you about. Some of them is the Baha Start, for example. but they sometimes have limited benefits depending on the patient's hearing. Furthermore, the surgical reconstruction for the external auditory canal often takes a backstage a little bit, where it needs some time, and often is done after the auricular reconstruction or at the same time of the auricular reconstruction, which means it happens around the age of 8 to 10 years old. So that's a 10-year period where they can't hear properly. Furthermore, these auricular reconstruction often don't get you the best performances. Additionally, not every child is a candidate for it, and they require a lot of care. Come now to the bone conduction implants, which from auditory perspective will provide decent auditory performance, but they come with downside because they're close to the area of reconstruction and may affect future reconstruction. So Osia was introduced in our region in early 2021, and we were the first academic center to adopt the performance for the device. And as been described before, its utility is really for conductive hearing loss, mixed hearing loss, and single-sided deafness. And as mentioned by Dr. Goldberg, is that a successful trial of softband Baha is very important, and counseling is very important. The recommended distance for the BI300 is usually at the limit of 5.5 centimeters because of to have an appropriate and optimum auditory performance. That is said, this is an issue for children with microtia. As you can see, if the child has single-sided deafness, for example, and this child with chronic ear disease, you can place the incision whatever you want. But if the patient has microtia, any types of auricular reconstruction that will happen will likely occupy every single space the patient needs for surgical placement if you want to place the device at 5.5 centimeters. This brings us to a study that we conducted. We want to see if you place the Osia system and the BI300 more posterior than 5.5 centimeter, will you still be able to get optimum auditory performance, and is it surgically feasible? So we conducted a prospective two-arm study where we placed children at 5.5 centimeters, an implant, and another group of children at 7 centimeter implant. And we wanted to see the difference in auditory performance in both groups. All these patients were performed as day surgery, except one due to medical conditions. And they were all fairly straightforward. And as I mentioned, most of them went home with the same day. We utilized a posterior inferior approach, which we've developed at our center. Basically, you create an incision that follows the posterior inferior angle of the Osia device, and you keep it more than 1.5 centimeters away from the device edge to prevent any stretching or any injury to that incision. And furthermore, when you do that, the device will be appropriately away from the incision will be appropriately away from the reconstruction site. Furthermore, you place the BI300, as we mentioned, 7 centimeters away from the expected position of the EAC. And the expected position of the EAC was determined in those patients who have microtia by determining the lateral canthus of the eye and taking a straight line from there that follows the TMJ, and about 0.5 centimeter from the TMJ was the estimated location of the EAC, which usually could correlate with part of the earbud of the microtia. And then a 7 centimeter was measured from there. This is an example of a case. As you can see, the incision places the device far away, places the incision far away from any reconstruction. And the exposure is appropriate for these patients. As you can see, you can perform the surgery quite easily, and you can perform your perpendicular drilling without any issues. Placement of the device is straightforward, and you can close the patients well without any issues. So what we've seen in our results, we've implanted 23 children in that cohort, with 6 of them had bilateral simultaneous. Our youngest was 3 years old, and that was part of the group 2, who had 7 centimeters away from the EAC. Both groups were similarly aged, and we have almost median follow-up of over 2 years. And as you can see, the age distribution, obviously the group that we attempted 7 centimeter distance had had more of those children that did not have reconstruction or that did not require reconstruction, which meant that we were able to implant them slightly earlier than the other group, which was at 5.5 centimeters. Furthermore, those group, although there was slight difference in the age, it wasn't statistically significant. Postoperative pain was equal. It was really a little bit pain the first day, and then by day 7 there was almost none. There was no real complications after the surgery. One of the patients in the first group had a bit of a skin-related erythema that was treated conservatively without any issues. And in terms of patient satisfaction of the Osia system was very high. And as well, we've adopted the quality of life questionnaire for all patients, except 5 because they were a bit young for that questionnaire. And all of them show significant improvement in their quality of life at 6 months post-implantation. The auditory performance was quite remarkable. We did not see any difference between placing the BI 300 at 7 centimeters away from the ESC or placing it at 5.5 centimeters, which meant that we were able to achieve optimal performance, auditory performance from the Osia system at 7 centimeters. Furthermore, the speech discrimination was also equal in both groups. So to conclude, placing the BI 300 at 7 centimeters away from the EAC is feasible, and it can result in improved auditory performance without affecting the auditory function of the device. And now the question becomes, are we implanting and giving auditory performance, assistance for these patients at young age? Maybe we can revisit implanting these children earlier, and what is the youngest that we can go and provide optimum auditory performance for these patients? Thank you, and back to you, JD.
May I ask a quick question, Faisal?
Sure.
One of the questions come through is whether any of these patients with the posterior inferior incision had reconstruction, auricular reconstruction done later on, and if so, were there any challenges?
So we have 3 patients of the cohort that had the 7 centimeter posterior inferior approach had auricular reconstruction using rib graft, and all of them were successfully on reconstruction. None of them had any device or reconstruction-related issues. The only thing we had to advise the plastic surgeon that not to use unipolar cautery, and just if they needed cautery, they need to use bipolar just because of the device being there. But otherwise, the procedure went well. We didn't have any infection-related issues, whether at the reconstruction or at the device itself. So it went well, and we're hoping for more long-term data with more patients.
Lovely, thank you. We've got a little bit of time, so I'll catch up on one question to Eva as well. Dr. Goldberg, if I could share a question with you then. MRI and CT scans you mentioned in your talk, and the question was, do all of your patients require MRI and CT scans, and if so, why and when?
Yes, all of our patients had MRI scan and CT scan. I said it in my presentation because we had to exclude intracranial pathologies because MRI is possible with the Osia system, but you have big artifacts in the MRI, and so you should do it before the operation. And the second, CT scans, yes, we currently we did it, but I think especially in adults, you do not have to do it. You can do the surgery without CT scan, but you feel probably a little bit better when you have it and you can plan it with the pictures with a CT scan. And in children, especially in the atresia cases, I would do it always because we saw some special anatomic situations in these cases, and so I would do it in children and especially in the atresia cases.
That certainly is our practice, because 1 in 3 adults will need a MRI scan during their lifetime, is the prediction, by the time they are 60 or 70. Now, with the new introduction of the MRI-compatible Osia system, will your practice change, or do you think the basic premise is the same?
No, I would not change the practice. I would do the MRI before the surgery.
Thanks very much. Back to you, Faisal, then.
Wonderful. That was very informative. So we'll now hand it over to Dr. Perini Adam. Dr. Adam Perini is an ENT surgeon at the Department of Otolaryngology Head and Neck Surgery at the University of Szeged, Hungary. He also has a specialization in radiology. His main field of interest focuses on the optimization of the surgical technique and challenges in imaging diagnostics of the full spectrum of implantable hearing aids. Dr. Perini, the floor is yours.
Thank you. Welcome, everyone. As next, I'm going to talk about our study that involved the MRI effects on the intracranial structure assessment. Well, MRI compatibility is, as indicated from the answers of the audience, is indeed a very hot topic. And we saw that the audience rated this as an important or very important question. Why is that? The number of implantable hearing aids has been increasing, and several medical conditions indicate an MRI examination. The majority of hearing aids and hearing implants is MRI conditional. It means that the MRI examination can be performed under certain conditions, but this not necessarily means that the implant will not limit the diagnostic value of the examination field, especially the head. The Osia system, the implanted part, the OSI 300, is like many recent implants, MRI conditional. We can perform MRI examination. This implant has a removable magnet, which means that we can perform imaging examinations, MRIs, without much limitation. So our study aim was to evaluate and compare the MRI-induced image artifacts that are attributed to the Osia system in terms of reliability, value of interpretation of selected intracranial structures. We wanted to provide an anatomy-based guide for clinicians, and we wanted to further assess the metal artifact reduction sequences which are available in every MRI scanners. We assessed the image quality. It was 3 observers. We used a 1.5 Tesla scanner and a 3.0 Tesla scanner. And we examined 14 different anatomical structures of the head region on a 4-point scale. We wanted to see whether the MRI image sequences that have special strengths in diagnosing special diseases, if they can be performed with good diagnostic value. Just to visualize that, the grade 0 was no distortion over the target structure. Grade 1 was where we saw slight distortion, which barely limited the reliability of interpretation. Then grade 2, the target structure was visible, but was not interpretable due to the artifact. And the grade 3 was where the target structure was not visible at all. We performed the general protocol of our institutional head and neck protocol, our inner ear and head protocol, which involved T1, T2, T2 flare, T2 cube. Each sequence has its strengths. And for example, the SWAN or SWI sequence is a unique technique where we can visualize small blood degradation products, and is a unique technique to visualize and diagnose special disease like a cerebral amyloid angiopathy in vivo. Or the inner ear and the internal auditory canal can be visualized nicely on the cube or Fiesta sequences and so on. As an alternative of the T1 and T2 sequences, we have the metal artifact reduction techniques, which we further assessed. Let's go to our results. To 1.5 Tesla, we took the mean of the three scores coming from the three observers. The score under 1.5 was acceptable, and over 1.5 was unacceptable. And from these results, we created a chart which looks nice detailed. But if you take, for example, the internal auditory canal that you'd like to visualize, if you suspect the patient has an acoustic neuroma, you have a selection of sequences that you can choose from. Here you see the sequences listed, and here you see the result if the magnet is in, or if you remove the magnet and you put a spacer, or you remove the magnet and you don't put a spacer instead of the magnet. And here we see that with the magnet in place, the T2, T2 cube sequences were not diagnostic, but if you took the metal artifact reduction technique, you can have a good visualization of the internal auditory canal with diagnostic value, even if the magnet is in place. And you can take the other anatomical structures if they are necessary, if they are in the focus of your interest. The 3.0 Tesla scanner was also examined within our study, and we got very, very similar results. And from these results, you can follow these charts so that you can have an easy look through of your interest. So to conclude, we were able to create an anatomy-based guide, which we offer to our clinicians, colleagues, radiologists, technicians. We will publish them. We saw that the magnet removal was beneficial in most of the sequences. There was no significant difference between the 1.5 and the 3 Tesla scanners in the results. The non-magnetic spacer did not cause any additional artifact. And importantly, the metal artifact reduction technique, that's what we recommend to use, is a very promising tool to create T1 and T2 series even without the need to remove the implant magnet, which we don't necessarily want to remove. So we have the option, and we can go through a nice and diagnostic examination with the Osia system. Thank you. And now I'm passing the word to Rebecca. Rebecca, please go on with the presentation.
Thank you very much. I'm Rebecca Dewey. I'm a senior research fellow at the University of Nottingham. I'm a physicist by background, having spent the last 12 or so years working in auditory neuroscience, mostly magnetic resonance imaging. As part of my work towards improving various steps along the pathway of MR scanning individuals who use implanted auditory prostheses, most recently, my colleagues and I have been working with Cochlear Belgium and the University of Leuven to start assessing the safety of cochlear and bone conduction implants at 7 Tesla by quantifying the interactions between implant components and the MR environment of the 7 Tesla scanner. New models of implanted auditory prostheses now pose very few safety concerns being MR scanned in field strengths up to and including 3 Tesla. So much so that we can now scan these individuals for research where there's no direct benefit to the participant of undergoing imaging. However, at 7 Tesla, it's a different story. Having previously been a research-only field strength for MR, it's now being approved by the FDA for patient scanning, and we're expecting in the USA at least that patients and members of the public are going to be given the opportunity to have diagnostic medical imaging at this field strength at some point in the future. So that, alongside the year-on-year increase in implant users, has prompted us to assess the interactions between the Osia and the 7T MR environment. We've assessed device functionality post-exposure to the MR environment, magnetically induced force and torque experienced by the implant in the scanner, changes to the magnetization of the implant's retaining magnet following exposure, scanner-induced heating of the device separately due to both RF and gradient fields, and image artifacts resulting from the presence of the implant. All tests were designed to align with the relevant industry standards and recommended procedures. So for device functionality, the device was exposed to the scanner's ISO center 10 times, which was deemed to cover the needs of around 99.9% of the population. All devices were found to remain functional once plugged back into the Cochlear software. For magnetically induced force, the device was suspended on a string and positioned close to the bore entrance where the spatial gradient field is at its highest. We then deflected the device by adding a known mass of something like plasticine or Play-Doh and measured the angular deflection to derive the magnetically induced force. Force amplitudes were found to be similar to those seen at 3T, and all of those with the retaining magnet removed were trivial. We here show the ratio of the gravitational force with the magnetic force. For torque, we used a low friction turntable such that the device was positioned in a realistic orientation with respect to the scanner field. The base of the turntable was attached securely to the scanner bed at ISO center, and the force gauge was attached using nylon wire, and then the turntable was rotated through 360 degrees, and the largest instantaneous force was recorded. Again, torque ratios here with the retaining magnet removed were trivial. For demagnetization, we used a total of 10 consecutive exposures, as with the functionality. And crucially, the retaining magnets were heated to body temperature before exposure, aligned with the bore, which is what you would expect when the device would be implanted in a patient. Retaining magnet strengths did not change considerably, but increased in strength by a few percent, which is easily remedied if necessary by applying a weaker external magnet. To measure localized heating of the tissue around the device, we created a tissue mimicking phantom gel plus sodium chloride, into which we submerged the device with fiber optic temperature probes attached to several different locations around the device. Gradient heating was measured by scanning with a sequence set to the maximum recommended gradient strength for 15 minutes, while the phantom was placed at the worst case position of 20 centimeters from ISO center. RF heating was measured by scanning with a sequence artificially controlled at 3.2 watts per kilo, positioned at ISO center, again, because that's the worst case condition. Temperature increases reached a maximum of 0.24 degrees C above background across all probes. Finally, image artifacts measured on a head-shaped phantom using a couple of standard sequences look pretty similar to those seen at 3 Tesla in terms of severity. So in conclusion, this is the first feasibility trial into the interactions between the Osia and the 7T MR environment. Our preliminary findings show no adverse effects on the implant within the predefined test conditions, and image artifacts look very similar to those seen at 3T. I must emphasize that these are preliminary findings and they do not yet imply implant safety in the 7T MR environment. This is going to be a much longer process to formally verify this, but it's a good start. You know, we've got justification for really pushing it forward, so we're really hopeful. So with that, I will hand back to our hosts. Thank you so much for your attention.
Thank you, Rebecca. That was very insightful. I have a question for you. The 15-minute scanning you quote seems like a long individual scan. Is that realistic?
So partly we're following sort of standard protocols for all of these measures. There's ISOs and procedures that we're just we don't want to reinvent the wheel in terms of, we want to use verified techniques. I mean, 15 minutes is probably a pretty good worst case scenario for a scan, but crucially, when you're imaging these individuals with things like metal artifact reduction techniques that Adam mentioned earlier, that's adding more SAR into the sequence, more pulses, and therefore that's going to need to be lengthened quite considerably when you reduce the SAR of your sequence. So yes, I could actually see them getting that long quite easily.
Very good. Since we have time, I'm going to ask also Dr. Perini a question. Which MRI sequence would you start with in order to achieve a diagnostic examination?
Well, I would. It depends on the pathology that I'm expecting, but definitely I would skip the normal T1 and T2. I would go for the metal artifact reduction sequences first, and sometimes we see that patients sometimes have to stop with the examination, and if we have a good metal artifact reducted T1 and T2, there is something we can start with our diagnostic measurements. So metal artifact reduction techniques.
Very good. I think we have a question from the audience. I think it's towards going to Dr. Goldberg. Can you see the question? Or do you want me to read it for you?
Yes, I can see the question is, it's the question whether MRI can be done after implanting Osia. And I have to correct, sorry for that. Surely you can do MRI scans with the Osia implant inside and after the operation. And with the Osia 200 implant, you can do 1.5 Tesla MRI scans with the magnet in place, and 3 Tesla when you remove the magnet. And yes, it's no problem to do it, but you have the artifacts, and probably you can't see the pathology of the brain in the region of the Osia implant.
Very good. I think we're getting a lot of questions, but we're getting short in time. So for that reason, I would like to just mention that this has been very insightful. Today, we had a chance to hear from experts in the field, whether surgeons or researchers and people that really are working, experts that are working to develop this field even further. We've learned about the development of the Osia system, and also what we've been using it for both chronic ear disease, single-sided deafness, and children with microtia, and advancements trying to get them fitted earlier, implanted earlier. Furthermore, we've also seen the adaptability and the compatibility with the MRI, especially with the new Osia 300 system. I think this has been very insightful, and hopefully will be able to push us further into the future in developing this field even further. I'm going to leave the floor. Thank you all for being here, and I'm going to give it to Dr. Jadip Ray to close the session.
Thank you. Thank you, Faisal, and thank you everybody for joining on this webinar. It's really been a learning experience for all of us, and also to share on the same platform. Questions have been interesting as well, and hopefully everybody gained from it. I certainly have, and it leaves me very excited with the future potential of all acoustic devices. Obviously, transcutaneous are becoming one of the main stays, with percutaneous still being available. So thank you, everybody, and till we meet again.